Good morning, everyone, and welcome to this interesting session. Cardiovalve hits the target. I love the title. How do we advance transcatheter valve replacement? So this London Valves has been fantastic. Everybody's raving about how many people are here. I've got to say, one of the things I'm most excited about coming here is seeing the target data. So I wanted to start by congratulating the Cardiovalve team and the investigators for bringing Cardiovalve for tricuspid to this end, to finish a European study and hopefully to get CE mark in the next few months. I think those of us who work in this area know how difficult it is to take a technology through a clinical study and for it to be able to get CE mark. So congratulations to the team. We can't wait for you to get your CE mark. So because of all the excitement today, we really want to bring you up to date on Cardiovalve. We really want to show you a Cardiovalve procedure, step by step, so you learn the steps. Hopefully you get intrigued, so when this device is available to you, you're going to be in line to try and use the device in your patients. We want to show you the target data, so to give you a sense of what kind of data we've gotten in the patients treated so far, and then help you understand better patient selection for Cardiovalve in tricuspid, but don't also forget this Cardiovalve in mitral. I'm joined today by a wonderful panel, Christian, Anna, Georg, and Scott, and hopefully we'll have a very exciting session.
Well, thank you very much. Good morning also from my side. And I would like to introduce, he doesn't need any introduction, Scott Lim. He is an expert in the field, and he's going to guide you through a step-by-step procedure and show you how Cardiovalve works in patients with tricuspid regurgitation. Scott, the floor is yours.
Thank you very much, Jorg. So this is a case, and we're just a recent case. We actually did this one in Vancouver, British Columbia, and we're going to go through this step by step because that's one of the really nice things I feel about. It's not just the valve that goes in; it's the delivery system, it's the sequencing that makes this a very controlled, iterative procedure. Here's my disclosures. And the idea behind this is we still find, in dealing with patients with tricuspid regurgitation, there's a real unmet need in terms of not just medical therapy. Even here, there's a subset of patients that aren't well served and really requires a replacement approach to them. And that's where the Cardiovalve and the Cardiovalve delivery system comes in. And here's just some examples that these are patients that we all deal with in different ways. And so this technology, for those that aren't that familiar with it, can fit both mitral and tricuspid anatomies with the same implanted valve. The delivery systems are different to account for the different curves to the left side or the right side, but the implanted valve has some really interesting, unique features where it has very minimal protrusion into the ventricle, be it left or right side. The anchoring mechanism is on the leaflets in a very firm way, and it has this inflatable skirt around it that fills with blood from the ventricle side to prevent perivalvular leaks. The delivery system, and this is the one specific to the tricuspid valve, is just that. It is specific to navigating from the IVC right atrium and to the tricuspid valve there. It has ability, it's been refined to be able to access that approach and then to get the delivery system back out. In many ways, you can't just use the same curves on the mitral side. You need to have an ability to gain yourself a different approach for height as well as pull laterally, which this delivery system now allows us to do. So as I go through this here's an animation to give everybody the sense of how we do this step by step. It's from a femoral venous approach, and this is relatively quickly here. We then orient, so in 3 dimensions, we're coaxial with the plane of that tricuspid valve. And as I mentioned before, this enhanced delivery system allows us, as you can see here, to pull it laterally, but still remain coaxial rather than just rotating. And then we deploy all of the anchors in the atrium and then drop just below the leaflet tips, but stay above the papillary muscle heads to then grasp it and then deploy the atrial flange and the rest of the valve. And while I know this is an animation, in real life, it is pretty much just that quick. It is a straightforward procedure there. Comes in 3 different sizes in the same crimp profile, all the way up to from 45 up to 55. There is a larger variation coming as well. The inner diameter of the inner frame is sized to allow it someday, if it needs to be revalved. So this is a particular case we did actually relatively quick recently. 80-year-old with the usual comorbidities, long-standing AFib, prior stroke and previous AVR, which in some cases can make imaging more of a challenge there. And she's quite symptomatic from her disease. She was felt to be not ideal for TEER therapy due to wide gaps, as well as due to her comorbidities, high risk for conventional surgery as judged by the heart team and one of my surgical colleagues. As you can see here, at baseline, she had a significant degree of tricuspid regurgitation. It was graded as massive, as a wide PISA. And her RV, though, was still reasonably doing well. The anatomy, we judge it by CT scan for more than just annular sizing, but also, say, space in the right ventricle for the delivery system, enough height in the right atrium to make the curves around there. And this patient was enrolled in the TARGET study. And how we approach it is, first, we pass a wire to the RV apex. We use, in this case, an extra small curved Safari. And then we want to make sure that wire is free. So we'll go ahead, as you can see my hands there, I'm moving that wire to and fro to make sure we're not behind chordae, that it is freely mobile there, because we're going to then follow it with the delivery system. That delivery system, even though it is larger than we do a TEER by a few French sizes, it still is very smooth, and the venous anatomy handles it just fine. Once we have the delivery system inserted, then we work to get it coaxial with the plane of the tricuspid valve, and we then open the the anchors that will grasp the leaflet. We do all that, as you can see here, just above the tricuspid valve. And then once we know we're oriented appropriately, then we'll drop in just below the leaflet tips there. As we drop below and come back up, we're grabbing the leaflets. We're using a lot, as you can see here, multiplanar reformatting on the echo, the TOE imaging, to say, have we grabbed all the leaflets going around? Being aware that sometimes one of the anchor can actually protrude through the leaflets where the commissures are, but we want to make sure we're not seeing multiple anchors missing leaflets there. We do this as multiple stages as we pull the valve and the anchors up closer, as well as making sure that we are parallel to the plane of the tricuspid annulus. And that's what we're taking a look here. And the very nice thing about this is a very slow, controlled, iterative procedure. The patients are hemodynamically very stable so that we can take the time to make ourselves feel confident that we have leaflet insertion in the anchors appropriately. And then we do the final deployment. At this point, it's everything is all set, and we're going ahead and releasing the atrial flange first, followed by the ventricular portion of the valve. And here's the final result there. We actually find that we may see tiny little PVLs, particularly in the anterior septal commissure, that while we see it here, by the very next day at time of discharge transthoracic echo, we aren't able to appreciate those anymore. This particular patient had a very nice result from the TTVR procedure with Cardiovalve, dropping her right atrial pressures, her renal vein pressures, and then started to diurese significantly overnight. So in overall context, we're developing more tools in our toolbox for treating our patients with tricuspid valve disease, and particularly those with larger gaps that we really need more than just TEER. And TTVR, particularly with the Cardiovalve, fulfills that unmet need. This system allows for a very effective delivery of therapy in an iterative, straightforward approach that really builds your confidence with it. So with that, I'll say thank you, and I'm open to any questions.
Well, thank you very much, Scott, for this excellent overview. Are there any questions from the floor? So feel free. Yeah, please, go ahead.
Just a quick question. Disregarding the size, I mean, if the annulus is optimal size, what are the rejection rates? I mean, given the size of the ventricle, how the rejection rate of potential patients?
Yeah, it's a great question. It's something that we're struggling with all the TTVR trials and mitral replacement trials as well, is that there is no device that is fitting 100% of the patients. In terms of, for Cardiovalve, our screen pass rate, more than just anatomic, but also all the other factors, including one of the big ones is a site may think that patient has more TR than the core lab does. We're somewhere around the 35% range of screen pass.
Screen pass? Not
Screen pass. So yes,
okay.
About 65% screen fail. And we think that we'll significantly change that with the soon to come out larger XXL version of the valve that goes up to 60.
So Scott, maybe let's just take that a little further. Take away the patient characteristics, right? Because a little bit now, this will become commercial, and commercial sites will be deciding what's the right technology for their patients. So it's going to become very much about anatomy. Mm-hmm. So when we think about anatomical exclusions, is the biggest exclusion then annular size, or are there any other exclusions?
So the biggest is still annular size, which we believe we shall address up to closer to 90% of it with the next size. But there are some additional exclusions. Right ventricular size. Occasionally we run into these patients with severe TR, big right atrium, but small right ventricle. And also, occasionally we run into the other phenomenon where we see, particularly little old ladies, that the right atrium, for whatever reason, doesn't dilate up in that direction, and we still need a certain amount of room for the delivery system in the right atrium.
Okay, right.
Do you see, Scott, any differences between the commercially available device and the Cardiovalve? You, for example, mentioned that the anchors are being developed in the atrium and not in the ventricle. What is your take on this, giving a limited experience we all have with both devices?
Sure. I do also think that there's a difference probably in the issues of heart block, more so not as much in the occurrence, but the timing of it, which may be more manageable. This particular device sandwiches annulus, atrial, and ventricular, and tends to not stent it open quite as much. Other issues in terms of PVL rates may be a little bit different. The delivery systems on both devices are very good.
Maybe I'm going to explore that just a little bit more because, you know, some of us have a lot of Evoke and use a lot of Evoke in our practice. What are the main differences with Evoke? Because I still have a lot of exclusion rates, and I was just thinking of one of them being the papillary muscles, for example, being too high, or that I can't create my gap in between the leaflets and the papillary muscles. Here, you just suddenly took that away from me because I don't have to worry about the gap, right? Because I'm opening in the atrium. Any other differences you can highlight or in relation to the delivery system?
But that you can do that as long as we have enough room in that right atrium. That very small subset of patients that, for whatever reason, has a small right atrium makes it more challenging, I find, and we've screened a few of those patients out for Cardiovalve. But that concept of if you have enough room in the right atrium, open the anchors up there, and you just barely drop it down enough to get the leaflets, helps probably in those patients where you've got a smaller Goldilocks landing zone.
Would you consider a transjugular approach in these patients with non-favorable angles between the IVC and then the right atrium?
So absolutely, with Evoke, I've definitely done that, but everything else, Cardiovalve included, is in the middle of a clinical trial, so we're more limited by trial protocols.
Yeah.
Very beautiful presentation. Just wondering, because you mentioned also the comparison to other devices available commercially, is there a point of no return, and where is it, and the deployment of the valve?
Yes, once those anchors are out, it's not a recapturable device. Yes.
Same as with Evoke.
Yeah.
Yes, absolutely.
Just a reminder, if you don't want to come up, you can also put questions through the app. And then the delivery system, it has secondary curve to take you off the septum?
Yes,
Okay.
it does.
Yeah.
Great.
Okay.
Thank you.
If there are no further burning issues, thank you very much.
Thank you. So we'll move to the next presentation, and Georg is going to take us through the interim results of the target study.
Yes, thank you very much. It's my pleasure, my privilege to report on the results of the Cardiovalve and tricuspid regurgitation patients on behalf of the target study investigators. These are my potential conflicts of interest. So the target study has been set up to, of course, evaluate, on one hand, safety of the system. Do we have too much bleeding, stroke, myocardial infarction, death, and so on? And then, of course, are we able to use this system to efficiently reduce tricuspid regurgitation? And this has to be shown in 150 patients, which are planned to be enrolled in that study, as you can see here. And the inclusion criteria I will show you in a second, but it comes without saying that these are the patients with severe to torrential tricuspid regurgitation having symptoms from this tricuspid regurgitation. It is an open, single-arm, prospective, non-controlled study, not by placebo-controlled study. And as I pointed out already, 150 patients are to be enrolled as we speak, and we will talk and discuss together the first 125 studies right now. These are the inclusion criteria on the left side, and I mentioned most of them already. Patient has to have symptoms, usually heart failure symptoms, and he has to have at least a severe tricuspid regurgitation to be a candidate for the study. Written informed consent and so on also is a no-brainer. And the exclusion criteria are more or less the same from other trials. So severe pulmonary hypertension, severe right ventricular failure, for example, unsettled issues in the left ventricle, unstable situations in the frame of an endocarditis, for example, are of course exclusion criteria in this type of controlled study. The endpoints are brought up here. We have an efficacy endpoint, and the efficacy endpoint was to reduce tricuspid regurgitation to less than moderate after 30 days in most of the patients, and that has been achieved. I will share this data with you in a second. And the safety endpoint is naturally a composite, reaching from mortality over bleeding issues to myocardial infarction, stroke, acute kidney injury, and so on. And this has all been meticulously assessed throughout the study. These are the study sites. It's a European-based study, but there are also very active sites in Canada and also in the UK. And for me, UK still belongs to Europe, even it is not longer in the EU. And most of these sites have been very busy to enroll patients in that study. And these are the baseline criteria. The usual suspects, if you will, elderly patient group, 77 years of age, and most of the patients female, almost every patient suffering from atrial fibrillation, prevalence of kidney injury or renal insufficiency quite high, above 30%, as you can see here, some risk factors. And what is important to note is that many of these patients were presented with massive and then enrolled massive and torrential tricuspid regurgitation, as you can see here on the right upper side. More than 70%, 73% of the analyzed patient I will share with you in a second. As a comparison, in TRISCEND 2, we had roughly 50% of the patients with massive to torrential TR. So it's a sicker population which has been treated in the frame of the target study. And as a consequence, most of the patients were treated with the large or the extra large device. We had already this 5 millimeter valve available, which made exclusion and screening failure a bit lower. Screening failure was within the study at roughly 30%, which is really an acceptable number if you compare that to other studies where we screen 20, 30 patients without enrolling any of these patients. These are the efficacy results looking at tricuspid regurgitation. On the left side, you can see 73% entered the study with massive or torrential tricuspid regurgitation. On the right side, you see the one-year data. Almost 100%, 97% mild or less tricuspid regurgitation. So the valve does a job. It reduces tricuspid regurgitation to mild or less in almost every patient. And this is accompanied by benefit in clinical performance, as you can see here, as assessed by 6-minute walking test on the left side, a nice increase from 267 to 315, and self-assessment of heart failure symptoms in the frame of the KCCQ score was also robustly increased by 21 points after 1 year, which has been shown also in other studies, but which is reinforcing also to see that in this study, mirrored by an improvement in New York Heart Class. As you can see here, most of the patients, I haven't mentioned that before, were in New York Heart 3 to 4, 70% of the patients, after study 90% in New York Heart 1 and 2. Safety has been also, of course, reported in detail. All-cause mortality up from 64%. All other endpoints really rare, like myocardial infarction or stroke. There were some bleeding issues at the beginning, and this caused the mortality of 6.4%. I will come back to that in a second. Pacemaker rate was at 18% in the study, which is well in the ballpark in comparison to the other studies which we know already for replacement in the tricuspid space. Halfway through, we got a new system, and a nice iteration of the system, a nice better delivery catheter, which made the procedure completely transcutaneous. And you can see that the bleeding rate in the last 68 consecutive patients dropped significantly, and that was also true for mortality rate, which was then only 4.4% in this very young technology in these patients. So I may conclude, and this is my last slide, I think it is safe to say so far, although it's only a single-arm study, that we can reduce very efficiently tricuspid regurgitation by using the Cardiovalve system, despite the fact that most of the patients in the study had massive or even torrential tricuspid regurgitation. The safety profile is more than acceptable, I would say, as I have shown you and as we may discuss in a minute or so. And the treatment of severe to torrential tricuspid regurgitation was accompanied by clinical improvement, 6-minute walking test, heart failure symptoms, data which I have shown to you. And the complete study will be presented as soon as possible. I think we have, if I recall it correctly, 150 patients lined up, and they have to be enrolled, and then we have to wait for the follow-up before we can report the entire study, but this will be within the next couple of months. Thank you very much for your attention.
Congratulations to you and all the investigators, really, on bringing this new technology so far. So maybe I'm going to ask Christian and Scott to make some comments on what you think of the data we have in the 120 patient data.
You know, a couple things. One, I second what you say about commending all of the people involved in this trial in enrolling these patients, and it's also really important, the follow-up data. You know, well, the first thing that jumps out at me about this is that, just like you were demonstrating, this is a sicker group of patients. There's a lot of more of these patients have significant torrential TR there, and that always goes with how the right ventricle is performing, and makes you question longer term, are we selecting the right patients? These shorter term results are very encouraging, but that's one thing that comes up. Second thing, in terms of the results, yeah, we are essentially in most cases eliminating the TR, and it's relatively safe, but not 0% mortality, which so that's the next question that probably comes up for you, Jorg, is why are we seeing the small percentage, but still there, of mortality? Is that, again, are we doing poorly on the patient selection side?
Yeah, that's hard to say so far, because it has been an uncontrolled study, if you will. But most of the fatalities were related to bleeding issues. And this has been resolved to some extent, but we have to remind ourselves this is a high bleeding population anyway, also independent of the procedure, causing mortality and hospitalizations. This is one issue leading to mortality. And then, of course, there were some patients who were not properly treated in the very early experience with the device, who had maybe a conversion, and that also caused in this very sick patient group, of course, problems.
So, Georg, just to tell one, when you say bleeding, you mean vascular access?
Vascular access bleeding.
And
yeah.
so maybe for the audience who doesn't know, how did the delivery system change? What's the enhanced delivery system you mentioned?
It is an enhanced delivery system in that sense that the capsule is very close to the delivery system. You don't have a step down. It's easy to insert it in the groin. This is one of the major differences. And then there are some material details which I don't know from the top of my head, but which can be reported by the company if anybody is especially.
Christian, I'm going to come to you in a second. Sorry, we just have a question from the audience.
Yeah, it was very impressive results. I'm just curious, the very few patients where it didn't work, where you had still a very massive insufficiency, I gather that was paravalvular, but do you know anything about the reason why they didn't work in those cases?
Out of the patients we have reported, the patients after 1 year, just a few patients had moderate tricuspid regurgitation. No patient with severe tricuspid regurgitation once the valve was placed in the patient, and that is due to paravalvular leakage at the commissures. Typically, you have paravalvular leakages at the septal side and at the posterior side sometimes.
Christian?
I would like. My microphone is not.
You try a different microphone.
Yes, this is working, thank you. So I would like to underline the point Georg already mentioned with the new system, because with the new system it's a true percutaneously approach, and as you saw in the preliminary data with the maybe subgroup analysis, the bleeding complication decreased dramatically with using of the new system, because it's a truly percutaneously access possible, and maybe this is also a reason why the mortality rate was in the first group higher than in comparison to the second group. So I think this is a huge advantage using the new system with the true percutaneously approach, which was not so easy with the first version. And the second comment from my side is, interestingly, 1/4 of the patient had a pacemaker lead already implanted. Maybe, Georg, you can make a comment on this point. Is this a problem using the Cardiovalve in pre-existing pacemaker leads or ICD leads?
I mean, it makes always situation more complicated. You can get entanglement if you place the system in the right atrium, but you can get along with this. It hasn't been an issue in none of the patients so far to implant the valve. It is an issue if you have two ventricular leads. Then it is not advisable to use this device, but also not advisable to use an evoke device that is applicable for all the replacement devices. Other than this, there was no complication rate, and we didn't have any isolation defects from the pacemaker, but we have to be careful. This is only 125 patients. We have limited follow-up. Same is true for the TRISCENT population. We have to wait longer whether we're going to encounter some issues with this pacemaker lead entrapment.
And maybe due to the bleeding complications, it's interesting for the audience, what is the anticoagulation regime after implantation? So is this a need for warfarin? Can we go for NOAC, and should we add aspirin on top, or what is your comment on this?
It was within the study at the discretion of the site, and usually the patient went back to the anticoagulation regimen he had before the procedure, and that was usually a NOAC. At the beginning, we had also, I think, a few patients. I'm not aware of a subgroup analysis. We had more patients being on a vitamin K antagonist, and this may also cause additional bleeding events. You don't need this, and you don't need. We haven't treated the patients with an antiplatelet drug.
You know, I think that brings up an important question that we as a community have not really addressed, is what's the right anticoagulation, antiplatelet strategy post-TTVR? Because we have more experience now with EVOQUE and a commercial experience, but that we're having some subacute thrombosis issues that seem to be correlating with, at least in the short run, ongoing patient symptoms, and that may be related to the failure rate of NOACs, which is a certain percentage there that's hard to pick up until things get too far down the line.
So I have two very brief questions for you. Well, maybe one brief, one not so brief. Did you jail ICD leads too, or were they only normal pacer leads?
I think there were. I have to look to the. I'm not sure about the ICD leads. There may be one or two patients with ICD leads. I would have to look it up.
And then the last question I wanted to ask was the pacemaker rate. In the second cohort, it looks very similar to what we saw in TRISCEND 2.
Yeah.
1 in 4 patients getting a pacemaker. Yeah. So do you think that will change moving forward? I mean, what are your thoughts to bring pacemaker rates down? Is it related to the valve design? Is it related to oversizing? Are there other factors we don't know yet?
I think we don't know about the risk. We don't know exactly the risk factors the patient brings in. For example, like in TAVI, right bundle branch block, maybe a risk factor in TAVI. Some at least claim. This is not clear on the tricuspid side. I think radial force is an issue. Oversizing is an issue. The things you mentioned. And so far, we haven't done a subgroup analysis which patient really got the pacemaker because of ABC. Okay. So we have to look into that, and probably the patient cohort is too small to really sort this out. But I think the Cardiovalve has a good chance for lower pacemaker rates because it does not rely on radial force at all. It's a sandwich system. Once you grab the leaflets and then develops the atrial flange, you don't need excess radial force to hold the valve in place.
So I think it's going to be interesting to see those sub-analyses in the future. Maybe you were just unlucky. You had a lot of patients with left bundle branch block in your study or other baseline conduction disturbances. So I look forward to that. So Anna, we're going to go to you to take us through the echo findings from Target.
Right. Good morning, everyone. It's my pleasure to be here and on behalf of the Target investigators to present this preliminary echocardiographic result from the Target study. These are my disclosures. So you've already seen this. Most of our patients entered this study with massive or torrential TR, and you can see that already right post-procedure, over 90, I would say 94, 95% of the patients that were enrolled actually ended up with a virtual elimination of TR, so really mild or less than mild TR. And also, this was already shown by Professor Nickening. Most of our patients were implanted with either a large or extra large device, which speaks to the fact that obviously these are patients that are quite sick and are coming to our attention at a very advanced stage of the disease. The Cardiovalve system is able to consistently and through the 1 year follow-up virtually eliminate TR, and you will see that up to 97% of the patients ended up at 12 months with mild or less TR. So this is a sustained reduction in TR grade. When we look then at the right ventricle, very important, RV reverse remodeling, we did observe a reduction in the RV and diastolic length, RV and diastolic base diameter, as well as reduction in the mid-diameter at end diastole for the right ventricle. So an important signal for reverse remodeling of the right ventricle, which is also testified by the reduction in the end diastolic area, which is something that we observed quite soon after the procedure, so at very early follow-up, already at 30 days. But we also see some signal in the reduction on the end systolic area, which starts to be more significant at more advanced stages of follow-up, so after the 6 months and then up to 1 year. When we look at RV systolic function, this is data that in a way reproduces also what we've seen with other technologies. We do see a decline in the classical metrics of RV systolic function, being that fractional area change, TAPSE, as well as global longitudinal strain. And this is probably a very direct mirroring of the reduction in the preload that we obviously obtain by eliminating the regurgitant volume from the tricuspid regurgitation. But very importantly, despite this apparent reduction in the metric of systolic function, we do see an important increase in RV OT stroke volume. So stroke volume increases despite, as mentioned, this decrease in classic metric of RV systolic function. And this, again, testifies the fact that what we're really seeing is an abolishment or a reduction in the preload by elimination of the regurgitant flow. And again, another very important piece to the puzzle here is that by eliminating TR with the Cardiovalve system, we're also seeing an important improvement in all the parameters of venous congestion. So RA volume goes down, IVC diameter at expiration goes down, and this is pretty consistent throughout follow-up. And we do also see an improvement in the hepatic vein flow. Many of these patients enter the study with systolic flow reversal in the hepatic veins, and the vast majority of them actually have an improvement in this parameter throughout follow-up. When we look then at the left side, you can see that most of these patients actually enter the study with preserved ejection fraction, and this tends to stay stable, if not slight improvement throughout follow-up. Again, LVOT stroke volume also increases throughout the follow-up of the study, testifying again an improvement also in what we have going now out in the systemic circulation, as well as cardiac output also increases. And we also looked obviously at the durability of the device. We didn't really see in this in the patient enrolled up to now, so in these 125 first patients, any event of leaflet thrombosis or increase in device gradients, and this is shown also in this graph. So this again being a very suggesting a very good durability of the device, at least up to the 12 months follow-up, and of course we'll need more data also moving forward to also prove this data. So overall, the TTVR with the Cardiovalve system effectively and virtually eliminates TR with the preserved sealing of the device itself and fixation durability. It does promote RV reverse remodeling with contextual improvement in forward stroke volume and cardiac output. As mentioned, there has been so far no evidence of valve or leaflet thrombosis in the patients enrolled so far, or need for redo valve-in-valve. We do see signals of reverse remodeling of the right atrium and IVC after a Cardiovalve TTVR, which is obviously a mirror of reduced venous congestion in this patient population. And Cardiovalve prosthesis is also maintaining native annular motion at base of the also at base at the right ventricle, with a very minimal right ventricle and right atrial presence. What do we have in our plans for the future? We'll always we'll continue to look at RV function, obviously, and valve durability, and long-term follow-ups. We'll obviously need to complete data collection and do also paired analysis, paired data analysis. And of course, we have in plan to perform detailed cross-analysis of echo parameters and put that in relation with clinical outcomes, in particularly quality of life and obviously mortality at long term. Thank you for your attention.
Thanks, Anna. Go ahead.
Yeah, that was excellent. I think the echo is giving us so much more insights into the patient population and the disease processes, because there's probably more than one. And so that's what I have a question on, Anna. I was struck by still the percentage of patients that have ongoing hepatic vein flow reversal even after we've eliminated the TR. And I was wondering as to your thoughts about that. Is it possible that these are, at least a subset of these, are patients that still have an atrial kick onto a non-compliant RV, or is there something else going on?
Yeah, that's a great observation. And to be honest, we are seeing something very similar also in other patient population, treated with other devices. So, in my opinion, what we haven't studied in depth yet is also the right atrium. What actually, to what extent RA compliance is part of this, and maybe there is also a component of medical therapy post-procedure that maybe we are not investigating that well. Ultimately, these patients go back back to their cardiologist. Some may, reduce diuretic therapy, and so that might also be part of it.
I was also going to ask, I'm not surprised when I see parameters of RV function decrease after TTVR because of us eliminating the TR because of the size of these devices. But when I look at this device, and I've held it in my hand, it feels very different to the other commercially available device. And the stiffness feels different. And when you look at an echo of an evoked patient, you see how it's pushing the base of the septum open. Here I see this valve come inwards, right, just by design in the RV and not pushing as much on the base of the RV. So I'm just a little surprised that you don't see a much more rapid recovery of RV function. Any comments?
Yeah. Well, I think what we see here actually goes very much in line with what you just mentioned, the fact that the Cardiovalve does not have all these radial forces, and we did see, in fact, also a reverse remodeling at the base of the right ventricle, which is something that in a way stands out as compared to other technologies, where we saw instead a reduction, a reverse remodeling in the mid-level of the right ventricle, but we're not really able to see that at the base of the RV. And I think, again, I'm really not surprised about the fact that we're seeing reduced RV function afterwards. I don't think it's really reduced RV function. It's simply probably we are unmasking, what was the real RV function before the procedure. Maybe it was hyperdynamic RV due to obviously, the excessive preload that we had.
Sure, because we are stealing the tricuspid regurgitation, so the right ventricle has more to do because afterload is increasing. But wouldn't that be very important for patient selection? Do you have any insight whether the baseline RV function is related to the development of, let's say, TAPSI after 1 year? Because there, at least at your standard error, you could have the notion that there are patients who had maybe even an increase in the RV function. So the question behind this: do we treat too late?
I mean, there is probably a subset of patients in which this affirmation is probably true. The real question is really how do we identify, these patients in which we are intervening too late, and is there an echocardiographic or maybe another also imaging, methodology that can help us really identify this patient? And within the Cardiovalve study, we're also started to compare CT data to the echo data, and quite surprisingly, we really find that sometimes they don't really get along that well. So I think we will need to investigate more into that. We would have loved to have more 3D data set from echocardiography, but the fact that many of these patients have huge RVs has really limited the amount of 3D data that we were able to collect. And that's obviously, not good, but that's the reality of this patient.
I have a question to you, and Scott, you have shown this hilarious result of this one patient having this large RV and then this really small RV after I don't know how many days. Is this friend or foe, or is this? Could we also learn for size selection from this, or what we're going to do about this, and if you connect this with pacemaker rates, for example?
Grabbing the microphone very slowly because I don't know the answer to that one. No, it's a great one, and as the RV shrinks, we've seen this with other technologies that anchor to the ventricular septum, say, and as the RV shrinks, PVL rates occur at a later time point. Obviously, not with this device because it anchors differently, but does that change how we should be looking at sizing for as related to pacemaker or other issues? Great question. I don't know answers.
So we have a couple of questions for the panel from the audience. So Anna, you mentioned that on echo there was no evidence of valve thrombosis, which is very reassuring. But as part of the protocol, is there any plans to do CTs to look for halt?
I think so.
No? No. Okay.
I mean, I think that will be guided, obviously, based on maybe increased gradients by echocardiography, which we have not seen. So.
Yeah. No, just because on the other valves, we've seen patients on CT with significant amounts of halt with still low gradients, right, where it's not produced clinical thrombosis, but we've definitely been more aggressive about their treatment. And that brings me back again to treatment. I'm still confused myself about what to do every day when I see a patient. I very much, like you guys, try DOACs, but all my valve thromboses have been on DOACs. And then I switched them to warfarin to try and get rid of it. And I haven't been able to predict which of the patients I should maybe start on warfarin from the beginning. What's been interesting, actually, the worst thromboses I've gotten have been in my younger patients, rather than the older ones. I'm not sure why, but again, just maybe because our audience member asked, just very quickly, all three of you use DOACs as your standard therapy?
No, clinical trial patients, I've been really pushing them to be on warfarin for at least the first 3 months, and then saying, okay, we can have that discussion at that point in time about switching you to a DOAC, although I still drag my feet a little bit.
Yeah.
But the therapeutic width of a vitamin K antagonist, adjustment of the INR is extremely difficult. Maybe in the frame of a clinical study it's a bit easier, but once we do that in the real world, it's gonna cause also a lot of complications. And the stent thrombosis, just to add this, the valve thrombosis I have seen so far were all in patients who came in also with other problems. They were taken off because they had a bleeding or they were in an inflammatory state. That at least was my very limited observation.
I'm just going to say, just because I think this is a real problem we're not addressing enough, mine have been very different. Patients, younger patients, very compliant. When I switched to warfarin, after 6 months it was gone. It took 6 months to get rid of all of ingredients to normalize. I switched her back to DOACs, the thrombus came back. Oh. And so now she'll be lifelong. A second one didn't get better and had to have the valve explanted because of valve thrombosis. So it's a real issue and we still don't know enough about it.
Maybe just a short question, because also from the TMVR side, we know that we're switching a lot between vitamin K antagonism and DOACs back and forth. I was wondering whether we are not causing more troubles than solving for the fact that we actually know from atrial fibrillation patients that we're switching, actually they do worse. What's your comment on that?
I think unless we get really strong signals that NOACs or DOACs are insufficient for this type of patient, we should stick to that for safety reasons. Because there are many more bleedings with vitamin K antagonists, but I don't really have the right answer. But at least that is our policy so far.
So we're going to move on to Christian, but as we do that, there's a very quick question for you and Christian from one of the audience. If a patient has a tricuspid ring, so an incomplete ring, can you treat that patient with Cardiovalve? Maybe not out of the clinical study, but in the future when you have it commercially?
Certainly.
Yeah. Thank you. So Christian, you taking us through now, we're going to switch a little bit to the left side and talk about TMVR with the Cardiovalve.
Yes, thank you very much for the kind innovation, and I hope to save some time because time is running already. These are my disclosures, and let me directly go into our case. It's a 81-year-old female patient with a history of coronary artery disease, a recurrent heart failure episodes, a chronic kidney failure, and atrial hypertension. She suffers from symptomatic severe functional mitral regurgitation and was symptomatic with a New York Heart Class II, but at a highly elevated NT-proBNP. The echo showed a severe MR, a mildly reduced LV function, and a good RV function. Patient deemed at prohibitive risk for conventional surgery. Of course, all of our patients are discussing in a heart team. You can see the logistic Euroscore and the STS score. And we found that the patient was not an optimal candidate for an MTA procedure to a very short posterior leaflet of approximately 8 millimeters. And that was the reason why we decided to go for TMVR. These are the echo images that you can nicely see that there's a huge severe MR. And of course, CT for screening is necessary, and CT confirmed available or a good candidate and anatomical reason for TMVR. I think you know already the system, but the valve, it's the same as we already mentioned before. The system is different to the tricuspid side. And what is new with the newer system of the mitral side is that you have a height-gaining mechanism option. And this is really a huge advantage. Before introducing the new system, there were some patients with screen failure due to the need of the height for the transeptal puncture. And with the new system, it's definitively no problem to do the transeptal puncture, and we have an option for gaining height during the procedure, and this makes the procedure much more easier. So let me go into the procedure directly. Transeptal puncture was done, dilation of the septum, as you can see here, with a 12 millimeter PTA balloon. Then we also use a safari wire like we do in tricuspid cases. Then it is still recommended to do a flossing maneuver with a Reliant or Coda balloon to be on the safe side that you are not interangle with the cords of the within the left ventricle. I think if you use a picture catheter for crossing the mitral valve, this is a situation where you should go for a flossing maneuver. If you go directly with a safari wire, maybe you can maybe there's no need for a flossing maneuver because the safari wire is wide enough. So dilation of the vein, it's a truly percutaneously approach also for the mitral side, introducing here of the system. It's a 32 French catheter, aspirating of and flushing of the sheath. And yeah, then you introduce the system to the septum, and there's a knob, a flexing knob on the catheter, as you can see in a second now. We flex the catheter, and then it's flexing and advancing the system. It is really easy to cross the septum. And after crossing of the septum, you have to position the valve also like you do in the tricuspid side, that you have an orthogonal position within the mitral valve. And if you confirm then with rotation, this is the same like on the tricuspid side, rotation of the first knob, you are opening the ventricular legs, as you can see in the fluoroscopy and echo. And this is also the time of no return, and you are committed to the procedure. And if you have a nice alignment to the mitral valve, you dive into the ventricle, just that you are above the leaflets and not interangle with the cords. And after you reach the position that you are below, not above, below, sorry, below the leaflets, then you pull back the system and catch the leaflets. And thereafter, you also do a spin, like you know it from the tricuspid side, that you catched every part of the anterior and posterior leaflet. You start at the whatever you like, but you have to be sure that you have A1, A2, A3, P1, P2, P3 catched. And if you confirm that all areas and segments are catched by the ventricular legs, then you press the safety knob, as you will see in a minute or a second, and you rotate furthermore the first knob, and thereby releasing the atrial flange. Here you can just see the spin maneuver, and you can nicely see that all parts of the anterior and posterior leaflets are on. And now is the safety knob, and with rotation of the first knob, the atrial flange is released. And directly after releasing of the atrial flange, you switch to the second knob at the end of the catheter for directly relieving the valve itself. And now the valve is completely released. And after relieving of the valve, you have to remove all of your maneuvers you did before, and you can nicely pull back the system without any interangle with interaction with the valve itself. As you can see here, the capsule, of course, has to be closed. There's no risk if you are below the valve. There's no risk for catching of the leaflets or something else. And if you are centralized, you can pull back the system, pull the stiff wire back into the pigtail, and then the pigtail is the soft end of the catheter. And you will then see the result of the procedure. Maybe, sorry, but I can, due to time is running. Here you can see the end of the result, the end of the procedure with a perfect result with only a tiny paravalvular leakage, and the valve is perfect positioned. And we close the femoral vein with 2 proglides poster. Let me shortly address that we treated so far 10 patients in 7 different hospitals. Pay attention that 7 different hospitals, 7 different operators did 10 cases, and these are the results from the first 10 cases. Mean age was roughly 81 years, so a very old patient cohort. 80% were male. This is different to the tricuspid target trial. All patients, of course, had severe MR. 80% had a functional MR, 20% had a mixed disease, and these were the acute procedural results with 40% the M, 30% L, and 30% the XL size of the procedure. Mean time of the procedure was 49 minutes. And the 30-day primary safety endpoint, there was only 1 death that was not related to the device itself. It was a sepsis due to a severe pneumonia, due to problems with the in- and extubation of the patient. There were no bleeding events, no vascular complication within these first 10 patients. And these are the echocardiographic results. As you can see, almost all patients had a non or trace MR after implantation. So in conclusion, TMVR with a Cardiovalve MR system is feasible in patients with significant mitral valve regurgitation. An effective sealing mechanism and abolishment of MR was demonstrated without, I think, risking LVOT obstruction. This is a point due to the very short frame of the valve, which is a huge advantage. In addition, that the risk for an LVOT obstruction is rather low. And an enhanced delivery system and valves low profile design enable a smooth, safe procedure with a short procedural time and minimal complication. And we are going for the AHEAD trial to evaluate the system in a randomized, or not in a randomized, in a feasibility study. Thank you very much.
Thank you very much for this really impressive case. We have a few more minutes.
4 or 5 minutes.
I have one question. Imaging must be easier. You have experience on the tricuspid and mitral side. Is it easier?
Yes, of course. Imaging is, of course, easier than on the tricuspid side. Yeah.
Right.
Okay.
There's again a question about, can you implant a cardiovalve in a mitral surgical ring? Any thoughts on the mitral side?
I think it depends on the mitral ring and how big the mitral ring is, and how the leaflets are looking so far. If we did not any case with mitral calcification or very thick leaflets, but depending on the ring, it might be possible.
If it is an open or semi-rigid ring, it could be possible, and it's large enough.
Right. And the last question I'll answer myself is, someone asked, is the implant the same mitral tricuspid? Yes, it is. What changes dramatically is the delivery system, right?
Scott.
I'll just add one more piece on the fluoroscopic images that, Christian, you showed on the far left side of the delivery system, doing a loop-to-loop and then putting the valve in place is impressive. We never see a MitraClip delivery system doing a loop-to-loop, let alone then being able to deploy the valve, bring the capsules back without changing your coaxiality. So
I've never seen a TMVR system do that either. I guess that's what you mentioned about your ability to gain height.
Exactly.
That's why you can do that.
I guess you don't have to do it. If you have enough height, you don't have to do this plus knob and turn it around, right?
Absolutely. That is only necessary if you do not have enough height or do have a low transeptal puncture. And it's good to have this option that you can treat this patient. But you are totally right. This is not a loop you will see in other cases.
So what is the lowest transeptal height you can treat?
To be honest, I do not really know. Maybe 2 centimeters, 1.5, something like this.
Yeah.
So it's
Wow.
really low.
Amazing.
That's very good. Okay, I think we have to finish, unfortunately. I hope we could show you that the system is readily available and readily usable to implant a valve in the tricuspid space, that the data are very encouraging we have, and that echo data show us also that there is a good evidence for right ventricular positive remodeling, and there's some more insight to come from this. And then we shifted gears to the mitral space, which is the most interesting part of this valve, that we can use it in both spaces. So there are more data to come. Stay tuned. Have a nice convention. Thank you very much for coming.
Bye.